Hello, everyone. Thank you for joining us today. My name is Rashika, and I'm the chairperson at SUPTA this year. This week, we are focusing on ENT, and we're very excited to have you all here with us today. Today, I am joined by Xavier, who will guide you through ENT. Xavier is a third year from the University of Dundee. To make the session as engaging as possible, we'll be releasing the polls throughout the session. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form. If you complete this, you will receive a certificate of attendance and exclusive discount codes to teach me surgery and pass the MRCS. Additionally, this session is being recorded. The recording and the slides will be shared on a Medall page a couple of hours after the session, so be sure to keep an eye out for that. We're also excited to share that we have an exclusive question bank and other resources on our learning portal, which is hosted on our website. So be sure to check that out after this session. If you create a free membership account with us, you'll automatically receive a discount code for 10% off the Geeky Medics Anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. Two lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE station. To enter, simply complete the Google form at the end of the session and enter the unique code that we will provide. The more sessions you attend, the higher your chances of winning. So be sure to stay for this session until the end and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the NDU, More Than Skin Deep, Medall, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Xavier.
Hey guys, so we'll be talking about epistaxis and the retropharyngeal spaces today. So it's quite a short topic, hopefully relatively straightforward. So we'll go through it, hopefully you learn a few things, and we'll have a poll at the end so you guys can answer some high yield questions. So again, just our partners here on the screen and learning objectives as well. I'm not going to go through them, but if you want to go back in your own time when we have the recording up, you're welcome to do so. So we'll start with some anatomy. So we have our skull anatomy here. So it's quite important to understand anatomy in order to understand physiology, especially in something like ENT. So first, we've got the roof, which is made of your ethmoid bone, specifically your cribriform plate. So remember, your cribriform plate is where your olfactory nerve can go through. It's also the frontal and the sphenoid. On your floor, you've got your maxilla, specifically the palatine process. And you're thinking like the front of the roof of your mouth. And your palatine bone. Okay, so that's more at the back. Then your medial wall that's your nasal septum. That's made of your perpendicular plate of the ethmoid, and it's also made of your vomer and your septal cartilage here in the middle. So your vomer below and septal cartilage here. Okay, then you've got your lateral wall, which is made of your maxilla, your palatine, your ethmoid. It's also got your concha in there, which we'll discuss a little bit later. And then, of course, your lacrimal bone and your sphenoid. So, yeah, all the bones of the skull, having a good idea of that is the most important, and then trying to understand what makes up each wall and each floor. Okay, we'll move on from there. Next is your innervation. So main things to know is you've got your sensory. So we're thinking your trigeminal. So your trigeminal V1, 2, 3, ophthalmic, maxillary, and mandibular. So your ophthalmic V1, that's your anterior ethmoidal nerve, okay? And then you've got your maxillary V2, which is your nasal palatine and greater palatine nerves, okay? So here's your anterior ethmoidal nerve running here in this image. Then you've got your autonomic, so that's your parasympathetics first. So you've got secretory motor to your mucosal glands in your nose, and that's for the pterygopalatine ganglion. So there's your parasympathetic in the green there. And then your sympathetic is for vasoconstriction, and that's via your superior cervical ganglion. Okay, so we'll move on to the next slide. Also understanding especially your trigeminal innervation for exams, man. It's always a top question they love to ask in anatomy. Next is your arterial and venous supply. So main thing for this that you need to know is Caselbach's plexus, which is also known as Little's area. So this is just kind of rich anastomosis of the nasal septum, and it's at the anterior nasal septum, okay? And this is really important because this is the major site for epistaxis, so we'll talk about that in a little bit. So you've got contributions from several different arteries. You've got sphenopalatine artery, which is a branch of your maxillary artery. Greater palatine artery, again, maxillary. Anterior ethmoidal artery, which is a branch from your ophthalmic artery. Posterior ethmoidal artery, again, ophthalmic. And finally, your superior labial artery, which is a branch of your facial artery. Lots of arteries supplying here, and all the anastomosis here in Caesalbach's plexus. Then you have Woodruff's plexus. I don't have it on this image, but we'll have it a bit later. It's right here at the back in your posterior area. And that's associated with posterior epistaxis, which is about 10% of epistaxis. And you've got your venous drainage. That's via your pterygoid venous plexus, your facial nerve, and your cavernous sinus. So thinking your cavernous sinus, you're thinking about your brain, okay? I'm not sure how many of you have done neuro already, if all of you had already, but that is for your drainage. So we'll talk about that later because that is involved in some pathology. Again, here I mentioned here creating a potential route for infection spread. So yes, your cavernous sinus thrombosis, usually via septic spread, is from a lot of pathology involved in nerves. So we'll talk about sinusitis and things like that. Okay, so next is our divisions. So it's pretty simple. You've got your olfactory region at the top, as you'd expect. That's your olfactory epithelium, your respiratory region. I say for air conditioning, and by that I mean warming air. And then finally your vestibule. That's at the very tip of your nose, and that's the hair for like filtration. Is quite important. In terms of some other anatomy, again, this is a side view showing your ethmoid bone. Sella tunica is another big one for where your pituitary gland sits. Another thing they love to ask in anatomy. Your sphenoid sinus here sitting behind your eyes. Your frontal sinus sitting on top. We'll go through these a little bit later again. And then again, highlighting different bones. So here we go. The palatine bone, like the back roof of your mouth, and your palatine process, which is at the front. Made up two bones, this roof of your mouth or floor of your nose. Okay, so nasal concha. So they're also turbinates, and then meatus are the things in between. Okay, so turbinates / concha, I hope I'm saying that right, are these bits here, these kind of bumps inside, and then in between them, the ridges, they're called your meatus. Okay, so one of the main functions of this is mainly just increasing surface area. It's pretty simple, and it's for warming and humidification. Remember, we talked about our respiratory division, so obviously that is right here. Just humidification as it passes into the lungs. Quite simple. Again, knowing some of your other anatomy here, hard palate, soft palate, uvula, tonsils. Okay. So in terms of functions, again, respiration, warms, humidifies, filters. Olfaction, I think it's pretty simple. You got your olfactory receptors for smell in the superior part of your nasal cavity. And then, of course, you've got your defense, which is your mucociliary clearance for immune function, and voice resonance as well. Contributes to phonation to some extent as well. And now we're going to talk about epistaxis. So I think quite a nice picture. Here we go. Here this shows our Woodruff's plexus. I didn't show in the previous picture. And we'll go through about some of these things. We'll talk about the rapid rhino. So to start, pathology and risk factors. So it's to do with rupture of your nasal blood vessels, typically in a very richly vascularized nasal septum. So again, we're thinking about our Caesalbach's plexus. So risk factors, anticoagulants, as you'd expect. Coagulopathies, we're thinking like our hemophilias or von Willebrand's disease. Trauma, big bang to your nose can easily start causing this. I'm sure someone's had it before. Dry air can cause it. Hypertension. Cocaine use is another key exam one that they love to throw in. Nasal infections, nasal septal perforations, picking, again, a big one. Insertion of foreign bodies, you're thinking for pediatrics. Juvenile angiofibroma, which is it's like a benign tumor that can occur inside your nose. And hereditary hemorrhagic telangiectasia, which is this abnormal blood vessel formation. And nose bleeding is actually one of the key giveaways that someone has this. It's one of the first signs people notice. Pathology, again, I mentioned 90% of epistaxis is involved in your interior, in your Caesalbach's plexus, usually self-limiting, as in it goes away on its own. And then you've got your posterior, which it's a lot less common, can be more severe, and usually you have to have some sort of intervention for this. You can't just pinch your nose and hope it goes away. Next, we have our management. So, sign management, quite simple. Pinching your nose, the soft air of your nose, firmly for 20 minutes. It says keep head in neutral position. You can lean forward. One thing you don't want to do is lean backwards, though. breathe through your mouth, and you can also use topical vasoconstrictors. Then there's cauterization. Okay, so this is when you use your silver nitrate or electrocauteries to burn it. And if you can see the source of the bleeding, this is when you can use this. You have to be able to visualize it though. You can also anesthetize it with topical local anesthetic spray and wait for 3 to 4 minutes. And those can then reduce bleeding like by means of vasoconstriction. So epinephrine is in a lot of local anesthetics, also lowers the blood pressure there to some extent, muscle relaxation. Then you have your nasal packing. So for anterior, you want to use Muracell or Rapid Rhino. So Muracell is at the top here. Now, how these usually work is you basically stuff it up someone's nose all the way back, and sometimes they use something like saline to help it expand so that it blocks off the area and prevents the bleeding. There's also Rapid Rhino. So here you can see in this bottom picture, and usually that's inflated rather than just using saline to make it grow bigger. And at least that way you can quickly deflate it when needed. Apparently less painful than your Muracell here. Then there's posterior packing that can be used as well if you, again, not being able to visualize the bleeding point. Then finally, there'll be surgical intervention. Not ideal, but remember we talked about some of those conditions that might cause it. In these situations, you might have to use surgical intervention. So there's a ligation of the sphenopalatine artery, and that's the endoscopic approach. Or you can use embolization in really severe cases when all your emergency management has failed. If it's really extreme, now this is quite rare, I very much doubt it come up in the exam, we're talking something that is risking someone's life, you can tie off the external jugular vein. Other things to consider, so you've got topical anesthetics such as Naseptin, which is a mixture between chlorhexidine and neomycin, and that just reduces crusting and risk of vestibulitis. Remember, vestibule is that front part of your nose. So itis being infection. And then obviously cautions, a big one they love to ask, I know in PASMED at least, is patients with peanut allergies. And you cannot use these, right, and neomycin allergies. So you got to watch out for just administering this. You have to make sure that you don't make the situation worse. Okay, next we'll talk about septal hematomas. So it's basically pretty simple. It's a collection of blood between your nasal septum and your mucoperichondrium. So this is your mucoperichondrium here. Okay, and then your septal cartilage, of course, in the middle, and you'd be your vomer beneath that, right? When your vomer about here. So it's this mucoperichondrium is a specialized layer of tissue covering your cartilage. Now, often this is due to trauma, like in a rugby match, get hit in the nose, people come up with a septal hematoma, and you get this blood accumulation, and it separates your perichondrium from the septal cartilage, and you get this disruption of blood supply. The big risk here is if you get cartilage necrosis, okay, because this disruption of the blood supply, and you end up with a saddle nose deformity. So it's something you need to address right away. Also, there's risk of infection. You get abscess formation, and then you can get this again. We mentioned the cavernous sinus as this area where things can spread. Risk of cavernous sinus thrombosis. Then, of course, you see this bilateral red swelling. So I'll have a picture of this in the next slide here. Bit of a disgusting picture, but here you can see this bilateral swelling on each side. Pretty obvious. Management's quite simple. It's exactly what you'd expect. Incision and drainage. Okay, you want to prevent the necrosis and allow the blood supply to be restored. You can then, after you've done your incision and drainage, you can then do your nasal packing to prevent the blood reaccumulating, right? You're blocking off the area, stopping the blood flowing back in and having the septal hematoma reoccur. And of course, antibiotics if needed. Remember, we're trying to prevent our cavernous sinus thrombosis, the septic spread, and then long-term follow-up if there's like deformity. Okay, so we'll move on to the oral cavity. So oral vestibule. So we have the nasal vestibule. This is the oral vestibule. This is the space between your lips, cheeks, teeth, and gums. Then you have your oral cavity proper, and that's the space inside the dental arches. Again, you've got your roof, so your hard and soft palate. So your hard palate here, okay, and your soft palate. Hard palate here, soft palate here. Your floor, which is made, again, your muscles, mylohyoid, genohyoid, and your tongue makes up your floor. Then you have your walls, which is your buccinator muscles. Remember testing that in cranial nerves, you tested buccinators. And then posteriorly, you have the oropharynx. Okay, pretty simple anatomy. Contents of the oral anatomy. So I put this this little tongue innovation. So again, it's divided to your anterior and posterior. So anterior is your oral, posterior is your pharyngeal. And I've got this little diagram showing your motor versus sensory innervation. A lovely exam question they love to ask about the special sensory branches, you know, being your facial nerve, talking about which muscles, so your hypoglossal, and then obviously your posterior is all done by your glossopharyngeal. Okay, your salivary glands. So you've got your major ones is your parotid, your submandibular, sublingual, and then there's obviously minor glands as well, which are less relevant in this case. And then teeth and gingiva, 32 permanent teeth in adults. Something to think about for salivary glands, you get a lot of tumors usually would occur in the parotid. In your submandibular, stones are the usual thing to occur here, like calcified stones. And then your sublingual could be like mucus that you get trapped in there. Okay, is the main pathology. There's plenty of other pathology, especially for submandibular. There's also there's plenty of other pathology. So in terms of tonsils, so they are part of Welder's ring. That's this ring here, okay? And it's basically lymphoid tissue guarding this upper airway, right? So you got your palatine tonsils. These are probably, they're quite important. They are located in the tonsillar fossa. So you see it here, your palatine, okay? So these are ones which are usually indicated in pathology, which we'll go over in a second. Got lingual tonsils, exactly what you'd expect. Being able to know where it is at the front and also your side view here, okay, seeing your lingual tonsils like beneath, right, just in the back of your tongue. And then you've got your pharyngeal tonsils, also known as your adenoids. So they are up your pharyngeal tonsils, and then you've got your tubular tonsils here, okay? So pharyngeal at the top, tubal, palatine, and lingual. I'm not going to spend too much longer on that. Your retropharyngeal space. So before I talk about some things to do with your tonsils, like tonsillitis, something to note is this retropharyngeal space. So it's this, it basically allows for like up and down movement of your larynx, your pharynx, your esophagus relative to your C-spine, right? And that's really important for swallowing and speaking. And the main thing to know for this is your danger space, right? So infections here, if you get an infection in this danger space, that can easily spread to your mediastinum, and you can get mediastinitis, which can be life-threatening. And then obviously, so just knowing the diagram here, knowing where it occurs, often seen in children as well. You see this infection in your danger space here. I'll show you an X-ray slide later demonstrating that. So tonsillitis, I said I'd talk about it. So two things you need to know really for exams is your center criteria and your fever pain criteria. So in NHS, fever pain is probably used more, but they are both used. Pretty simple. It's inflammation of your palatine tonsils. So if we go back here, remember your palatine tonsils. Remember I said they're the most thing for pathology. Okay, so inflammation of them, and it's often viral. So Epstein-Barr virus, or it can be bacterial, so group A strep. So I was thinking about what antibiotics you're going to give for that and what you're not going to give. Remember, thinking about amoxicillin. Your center criteria, so you score 1 point for each, right, maximum of 4. So you either have presence of tonsillar exudate, tender anterior cervical lymphadenopathy or lymphadenitis, history of fever, or absence of cough, right? And you get your score, and this can give you your likelihood of isolating streptococci, okay, so your bacterial. Your fever pain, I think it's quite a lot more precise. Maximum of 5, so fever over 38. It's in the name, right? So fever, 38, and then pain being PA, or I guess it's I from inflamed tonsils N. So purulence, so that's your exudate, attending it rapidly, so 3 days or less, inflamed tonsils, and no cough. So remember, no cough is a big part in how you're going to diagnose this, right? In the causative organism. In terms of management and complications, so Recurrent tonsillitis, another big exam one they like to ask. So 7 episodes in 1 year. That's when you're looking for tonsillectomy. It's not done the same way as it used to be in the past, where they try and take them out. Even if you had 1 or 2 occurrences of this. There's other guidelines as well. Greater than or equal to 5 per year for 2 years, or greater than or equal to 3 per year for 3 years. Or the other criteria is significant negative impact on quality of life. So if you're missing a lot of school and a lot of work. So your question might say a child has had 3 in the past year, and they're significantly suffering from this, and they're missing school all the time. You're then immediately thinking, right, I might do a tonsillectomy to resolve this. So that's removal of your tonsils. Complication of this, you can get peritonsillar abscess known as quinsy. Okay, you can get retropharyngeal abscess. Maybe we talked about retropharyngeal space, right? Danger zone, and parapharyngeal abscess. So abscess is a big one. And suppurative basically being production of pus. So non-suppurative, you're thinking rheumatic fever or post-streptococcal glomerulonephritis. I'm having a tongue twister. So rheumatic fever, again, is your inflammatory from like strep throat, affects your heart, joint, skin, nervous system, and then your glomerulonephritis is your kidney condition. So you got, inflammation in your kidneys and can lead to kidney failure. Your surgical complications. So this is if you do a tonsillectomy. One of the big things is primary hemorrhage, right? So less than 24 hours. So all post-tonsillectomy hemorrhages should be assessed by ENT, and you manage it by immediate return to theatre. So if you have hemorrhage following this tonsillectomy, it's immediate return to theatre, right, after an assessment by ENT, okay? You do not just leave it alone and ignore it. Secondary hemorrhage, that can occur about 5 to 10 days post-op. Treatment with that is readmission and antibiotics. You got to be really careful, right, in tonsillectomies, really careful. Next is so I told you I talked about this. So here is a lovely X-ray. Okay, so this lateral X-ray, and you can see this kind of little bit of soft tissue swelling, right? It's quite you can see with the arrow, it's right at the tip of the arrow, and that's showing a retropharyngeal abscess. Not the easiest picture to see. I really struggled to find a good picture for this. The main things though that you're looking for is less just on your X-ray. You're looking for the red flags, right? So your red flags is your severe sore throat, your dysphagia, okay? So you're thinking like difficulty swallowing, your odynophagia, which is like discomfort while swallowing, like pain or discomfort while swallowing. And then you got neck stiffness, torticollis, which is like difficulty turning your head, stridor, remember with breathing, respiratory distress, muffled voice, and a bulging, the big one, which is probably the most obvious, is your bulging posterior pharyngeal wall, right at the back. Okay. Again, in terms of management, so you immediately urgent area assessment. You're worried about. Remember your ABCDE, right? Risk of obstruction. IV broad spectrum antibiotics. So your ceftriaxone. Remember your cephalosporin antibiotics. So bacteria cell wall synthesis, right? Inhibiting that. And then your metronidazole, which is disrupting your bacterial DNA. Then you have your CT neck with contrast to confirm the diagnosis. Obviously, X-ray is good to some extent, but you're more visualizing bones, not soft tissue. That's where you've got your CT neck to confirm the diagnosis. You use surgical drainage, and then again, you need to watch out for the airway. Paranasal sinuses. So, topic close to my heart. When I was a lot younger, I got sinusitis, and it wasn't very pleasant. Very painful, I must say, and it can be quite risky. It can spread to your brain if you're not careful. So, knowing the anatomy, so your frontal sinuses. Remember, I mentioned your ethmoid sinus behind your eyes, and your maxillary sinus, and your sphenoid sinus. Remember, this lines up a lot with the bones, right? So you're expecting, like, in terms of remembering the names, right? So in terms of anatomy, so your maxillary sinus, that's your largest. Again, cheekbones, drains into your middle meatus, maybe your meatus and your turbinates. Frontal is in the forehead above the eyes, drains into your middle meatus again. Your ethmoid, right behind the eyes, or right between and behind, and that drains into your middle and superior meatus, and your sphenoid sinus, that's behind your ethmoid sinuses, and that drains into your sphenoethmoidal recess. Okay, that's another one they might want to ask in terms of where do they drain, right? Okay, so trying to remember that. In terms of clinical relevance, again, sinusitis, most commonly your maxillary and ethmoid, and you can have some anatomical variations which might make you more susceptible in terms of the size of them and the size of the areas they're draining to. The function of them, the main function, they're air-filled, they reduce skull weight, they enhance resonance. That's as far as we know. Okay. Complications. So you can have orbital complications, right? So your orbital cellulitis, again, is a red flag emergency. You don't want someone to lose their sight. So infection that spreads to the eye tissues, you get pain and swelling. And you can get an abscess from that as well. Then you've got meningitis, so spreading to your meninges. So remember, your protective layer around your brain and your spinal cord, your protective membrane rather. You can get brain abscess again. And then again, once again, the cavernous sinus thrombosis, vision loss, cranial nerve damage. Remember, that's that large vein at the base of the brain and like behind the eyes. And then you chronic sinusitis, so polyps. They might obstruct the sinuses, worsening symptoms. Polyps is another one they love to ask in exams. If I was to give you a key tip for that, just remember that if it's a unilateral symptom or if they're bleeding, then you're immediately thinking further investigations, right? It's a red flag for polyps, okay? Then osteomyelitis, chronic bone infection, as you'd expect, and then mucoceles, which is like these cyst formations, and that can put pressure on adjacent structures. Those are the four main things to remember. Then we have transphenoidal surgery. So this is our final slide. So this is basically how the pituitary gland is accessed, right? Looks a bit like a lobotomy. So it's accessed through your sphenoid sinus, via the nasal cavity, okay? There's your sphenoid sinus here. And that's directly below your pituitary gland, allows it to access it, ideally with minimal disruption to other surrounding structures. In terms of anatomical considerations, main two is optic nerves and internal carotid arteries, right? Optic nerves being a big one. You got to be really careful with this. You don't want someone walking out blind or bleeding everywhere. In terms of management, you can do a CT or an MRI to assess the sinus anatomy. Remember, I talked about anatomical variations in sinuses, right? So you got to plan this out beforehand. It's not going to be the same in everyone. Again, sinus variation, so asymmetries that can affect the access, and it can increase complications. And remember your sella turnica, or I can't remember how to pronounce it, as a key kind of structure they love to ask in exams. Okay, I think that concludes the PowerPoint. So I think we're going to move on to some poll questions, if I'm correct.
Yeah, so I've just released the first question, which is, what is the most common site for nosebleeds?
So I'll give you guys a second to answer if you want, if you could in the chat. I hope I've drilled this one into you. Remember, there's two main sites, but this one is the most common, 90%.
Majority have gone with A, which is Giza vas plexus.
Perfect, guys. Yeah. So remember, Little's area, most common site. It's where all your blood vessels converge. Your anastomosis, right? Going to the next question then.
Okay, so the second question was, which of the following is not a function of the paranasal sinuses? And majority have gone with protect the brain.
That's correct, exactly. So they help reduce the weight of the skull, they contribute to voice resonance, and then also they produce mucus. But again, weight and resonance is like the primary functions of them. Yeah. So yeah, exactly. It doesn't protect the brain. In fact, and if anything, it can put the brain at risk due to your spreading infection. Go on to the next question.
So for the third question, which anatomical structure is most at risk during transsphenoidal surgery? Majority have gone with A, which is optic nerve.
That's perfect. Yeah, that's exactly right. Again, we're also thinking about our internal carotids. Don't forget that. But yes, it's your optic nerves and your internal carotids. Perfect. And then we've got one final question as well.
So we have 75%. So the question is, what is the most appropriate treatment for a septal hematoma? 75% have gone with surgical drainage and 25 have gone with nasal decongestions.
Right. Yeah. So main thing got to remember for this is you need urgent drainage, right? You want to prevent necrosis. You want to prevent tissue death because of the pressure that bleeding is putting on, right? It's going to disrupt the blood supply to your cartilage, your septal cartilage. You then usually want to pack it. Remember I said you'd pack it after to prevent the blood leaking back in, and then your antibiotic option is more if it gets infected. So yeah, so your main thing you want to do though is your surgical drainage, right? You want to prevent those complications. Again, you're thinking of your saddle deformities, or spreading to your cavernous sinus as well. Yeah, I think that concludes all our questions. So I know it's been quite short and sweet. I think it's a relatively straightforward topics that we've gone through. The main thing, which I'm sure people struggle with, I struggle with it too, is your anatomy. There is a lot, especially in your skull. But if you're interested in ENT, it's definitely worth learning. At least once you've got it there for life. And it really helps with kind of understanding the pathology of some of these conditions. So yeah, I think that's it. Thank you so much for coming.
Perfect. Thank you, Xavier. That was very helpful for revision. I hope you all enjoyed this as much as I did. If anyone has any questions, please do put them in the chat. In the meantime, I'm just going to go over a couple final bits. So the feedback form is now available in the chat. Don't forget to fill this out to receive your certificates and also discount codes to Teach Me Surgery and pass the MRCS. Also be sure to complete the Google form for a chance to win free access to the Geeky Medic surgical flashcards and their OSCE stations, the link for which again is available in the chat. Our next session will cover urology on the 31st, which is next Monday at 6:30 p.m. We'd love to have you guys join us again. Make sure to follow us on our social media platforms, the links for which are available in the chat, and you will be able to receive updates on our upcoming events via these platforms. We've also posted additional SBAs on our learning platform, so definitely check that out. You can
give
do
that a
this
check out, guys. We worked hard on those single best answers, so it's worth checking out. I think they're really some of them are quite solid, and there's some good descriptions on each answer, so you can kind of work your way through what's right and wrong.
Yeah, definitely. So have a practice of that. You can do this through our website, which again, the link is in the chat. I hope you found today's session helpful. Thank you once again for joining us today, and we look forward to seeing you at our next session next Monday. Bye,
Thank you so much,
everyone.
guys. Thank you. All finished. Is there any questions in the chat at all?